Good morning, everybody. Or afternoon, actually. So let's start our SEVA VentRounds today. And we're going to try the topic of Underassistance. And we're going to do these reading waveforms from CHEST 2024. This is the second time we do it from here that it falls there. It's October 10th, 2024. The disclosure is there's no endorsement of any mode, ventilator, or manufacturer. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. And both Rob's and myself, disclosures and conflicts of interest are highlighted here. Please remember this is a recorded session, and we may call upon all of you to speak, or if you just want to speak, just unmute yourself and connect as you should. If you're a respiratory therapist, just fill your evaluation as you're finishing that. You'll see a QR code, and when you do that, there's an evaluation. And if you fill it within the day of doing this, you will get your CRC. This is our basic SEVA knowledge. And what I wanted to highlight here is whenever we're in volume control, we control volume, right? And during inspiration, and then during expiration, what you control is pressure. So if the patient has any effort of any sort, where the area where you would see it is in the pressure waveform. And this is a key skill that one has to have during watching volume control, is to see where the waveform deviates. So if the patient takes a breath in, you would expect that to move down. But if the patient takes a breath, an expiratory breath, while they are doing this, then the pressure would move up. So if or it was fighting against the ventilator. But usually what we're going to see is that the pressure moves down when the patient takes a breath in. And so that's what we call work shifting. And that's relevant for you because of how we are going to start looking at this patient that I'm going to present you the graph now. Rob, any comments here?
Nope.
All right. So let's start with this one, and I'm monitoring the chat on the lateral image because I'm presenting this from from all the way over here. So please, what do you think is the tag for this patient? And I put there the tag. Actually, this is a servo use, so you can use either your Rosetta card or your app. Take a look at what is going on. So put on the chat what do you think is the tag for this? Good. Rapidly, Annika jumps in and says this is volume control CMV. Yes, and that becomes very evident. Actually, just because looking at the pressure waveform, you're going to see that there's essentially no pressure waveform. It looks almost flat, except this one over here. But the flow doesn't look geometric as we're used to see it. And this is one of the challenges that we sometimes have for people that are trying to read these for the first time. You're expecting a geometric shape. And this is a good example of that. So the ventilator is delivering a descending ramp flow. And you can see that the flow that is being manifested by the ventilator on the screen is very different. It doesn't look like identical, which is what we would expect if this was volume control. And the reason for that, it can be two reasons. And three. The first one, that it was not volume control, and it was pressure control. The second one is that the sensor is at the Y. And the third one is that this is a simulation that the ventilator generates to tell you that there is PMOS, and this is how the flow would actually look if it was at the Y. The answer for this one, for this particular ventilator, and this is what we're seeing here, and this we talked to the engineers for this ventilator, is that this is a simulated waveform. So it's simulated what it would be if it was measuring at the Y. Rob, comments?
No, and the reason why it's not straight lines is because there's a effect of the PMUS. The patient is essentially sucking gas from the compressed gas in the circuit, and so it's a little bit noisy. That's because of that.
but this would look something like that if there was no noise at all. That's what you
Yeah,
would see. Well, this would be a straight line rather than
right. So
like
if the tube compensation was turned off and the simulation was gone, or the flow sensor was being measured at the control valve inside the ventilator, or if the patient was paralyzed, all those things would give you the red line.
yeah. And and one thing that we learned is this symbol down here, which you can
Yeah.
see here, is a marker that compensation is on, and so you see this curve. If we turn it off, which there's a way to, then you would lose that waveform, and it would look like actually it's being delivered by the ventilators. Just FYI, no need to do that, but it's just something for you to be aware. You have to be aware of a couple of things that are also kind of unique to this ventilator, although others may do it too. One is that normally when we have been trained on volume control, we train that there is a square waveform or a descending waveform. Some ventilators may have a sinusoidal waveform, but there's not many that do that. Well, what this ventilator manufacturer decided to do is that one, you can set the rise time for the flow, so you can alter it so that it has a slope, and it's based on time. So you set the time that it takes to reach the peak flow. And you can see that there's such inclination here. And the second thing that you can set is not only this one, but you can also set where the flow ends. So if you imagine this is the peak, you can set it to finish at 40% or at 80%, or all the way to 0, depending. You can move that value, and it's a setting that exists in your settings, but that will alter how the waveform would look and how then the flow is delivered. The reason for doing this and the benefits have not been studied, and I don't think that you could make a strong statement in favor or against. I would just say that it may be useful for somebody with some PMOS and you want to match the flow, but otherwise it really doesn't make sense, and it will affect how the waveforms will look without a doubt. Rob?
Yeah, and the disadvantage is if you set the rise time greater than 0, then the initial pressure isn't going to reflect just resistance, like we like to say. And if the end flow is not 0, then the end inspiratory pressure is no longer going to reflect only elastance. So you lose information at the bedside when you do this.
Correct. So the second part, so we know this volume control, this is all mandatory breaths because we have a set time, so all of them are the same size. And then and in this ventilator, you can have, depending if you press a button or not, it can change from D to S. And D meaning dual and S meaning set point. And we know that this is not dual by looking at the waveforms because there's a lot of PMOS. And Ariel highlights that there's a lot of PMOS. And if this was a dual, then we would see this flow actually changing into pressure. So if there was with this amount of PMOS, you would expect actually the flow to rise. So that's that. So vc-cnvs set point. So what is the load for this patient? Yeah, good job. It's all PMOS. So this is important for you to recognize that during inspiration, there's PMOS. During expiration, there seems to be also PMOS. And this is a classic one in which instead of having the exponential decay, you see, so compare this one, which got truncated, but you can see an exponential decay with this one, in which it has this bulging away from the baseline that tells you that there's PMOS, the patient is actively exhaling. So it's all PMOS, and it's hard to see. And then in this one over here, it would be hard for us to read this but it's most likely all elastic in this second breath. But obviously, this is after the patient has received two tidal breaths of 450. So one barely exhale and another one. And so this patient got 900 cc's of tidal volume, which is just preposterous in many ways. All righty. So let's go into the PV discordance. In terms of trigger, do you see any abnormality? Is it normal, early, late, false, or failed? Okay, good. Trigger is absolutely normal. I concur. So even though the trigger is in pressure, and you see that over here, it seems to be triggering not major delay, and then the device triggers. And then if you look at the flow, you see that it crossed baseline and it triggered. So perhaps not an issue, I would say. During inspiration, what do you see? Assistance, over or under assistance? Yeah. Yeah. So here you know it's under assistance because the pressure is coming under assistance. The pressure in volume control goes under the baseline. So that's the way to remember that. So this definitely has under assistance during inspiration. Yeah, it's basically it's almost like CPAP, crappy CPAP, but yes. And then the cycle. How's the cycle? Normal, early, late. Yeah, so this is a tricky one, but yeah, so in this one over here on the first breath, you'll see a little bit of amputation of the tip, so maybe early, but in the second one, it's definitely early. The breath was started by the patient, and the second one it's a double trigger, and the second one you see it triggered by the patient, so this is definitely an early cycle. So the machine cycled earlier than the patient, earlier than the patient. And finally, during expiration, we already defined this, that there was evidence of expiratory work over here. So really good job, guys. You recognize this very well. I would highlight to you a couple of items, and this is one of those features in which you can see that the patient took a breath in and didn't exhale anything, exhaled very tiny, then the volume resets to zero because we triggered another breath. You see another breath was triggered, the machine resets, another tidal volume is delivered, okay? And now the patient exhales, and actually it's exhaling with expiratory effort. You see the activation. And the patient exhales obviously more than the second breath. And now if this allowed you to see it, this patient is probably exhaling all the way over here, and then it resets and another breath starts. That's how it happens. Roberto?
Yeah, the important thing here is that if you just looked at what the screen's telling you, it looks like the patient got 3 breaths at around 400 mLs. But the fact that he didn't exhale on the second breath and got another breath in, that means he's got, probably around 800 mLs. And you can verify that by looking at the flow waveform because, again, the area between the flow curve and the horizontal axis is volume. So that big exhalation has an area of about those two inhalations added together. In fact, it is that. That's what it has to be. So that's how you can verify that that was a huge breath, a double breath.
Excellent.
And there's no alarm apparently, so that's not a good thing.
Yeah, it won't. There's even though this seems like a pattern that could be identified, it's not identified. Alrighty, so what would you all do when you see this patient? What would be your first action? Yeah, good job, Annika. This was a trick question, but you fell for it. I mean, you answered it correctly. The answer is, what's your goal? Excellent, Ariel. That's perfect. That's the first thing that you think, because if your goal is going to move towards safety, then this patient's respiratory drive is very high and needs either sedation, paralysis, pain control, bicarbonate, dialysis. I mean, you choose. And if the goal of this patient is comfort, then it would change and you may use a different mode. So in this case, the clinicians at that time decided to change the patient and they changed him to this mode. So mode is this, what's the tag for this patient? Thank you. Yeah, excellent. Good job. So pc-cmvs. So they changed from pressure control, that's from volume control to pressure control. And now I would um, make it evident for you that the patient now is on pressure control. We're controlling the pressure. They are all mandatory breaths, but this is an adaptive. So you still set the tidal volume, in this case 450, and the machine will move up or down the pressure to achieve the tidal volume. Okay? So now what is the load on this patient? Is it elastic, resistive, or PMOS? Excellent. Yeah, it's pure PMOS. Really good during inspiration is PMOS, and now you can see it very nicely how this patient gets, instead of having this exponential decay, all this area is PMOS. And now there's some work out there coming on trying to assess the curvature of the curve and trying to estimate from their PMOS. But for you, it just means this patient has presence of PMOS right now. This is what it means. And you can see that actually the ventilator is maintaining the pressure really well. And then at the end of this, the patient exhales or changes from inspiration rapidly. And you can see this beak, which essentially is a marker that the ventilator cannot pressurize or maintain the pressure because the muscles are moving to expiration. And then you see that beak there. We can talk a little more about that. And during exhalation, I would ask you to look at this one, and this one probably shows a little bit more of that convexity, but this one looks more straight, and this one probably a little bit more curved. So I would suspect that this patient still has some degree of PMOS during expiration, but sometimes it's hard for me to see it, and it becomes more evident when you're looking at the patient in front of you. But I would suspect that there is active exhalation here, just because this is not falling the way that it should for this patient. But it could be resistive load too, but I suspect that there's PMOS there. Roberto?
Agreed.
All righty. And I highlight here the area where the PMOS would be. And then in terms of trigger, so how's the trigger for this patient? Yeah, so now it becomes a little bit more evident now that we have less noise. You can see that it triggers, and it's again still pressure triggered. And you can see, and I'm gonna just amp, I don't know if I'm gonna do this well, but yeah, I did it. But you can see how it crosses and all the way. So and now that I see it better, it probably was the same on the other one. And you could argue that this patient should be, with this amount of work of breathing, on a flow trigger to allow that to happen easier for the patient to breathe out. So I would say that yeah, it's probably on the later. Although for those that said normal, I could easily have read that as normal too. Uh, so some optimization could be done there just based on the amount of time that it's going here. In terms of assistance, is this assistance, over assistance, or under assistance? Yeah, this is a tricky one because it has to do with how we diagnose stuff, right? Give me 1 second. I'm getting a spam call. Okay. All right. So the challenge here is that there is definitely assistance from the ventilator. The pressure is not dropping below the baseline, right? And so the tidal volume that we see here is higher than what is expected. We don't know if it's above the mLs per kilo that are for this patient. So the question is this patient getting enough support? And from looking at this image, you would need to measure PMOS to have a better idea. But it may be that this patient is under assisted, and there's a couple of suggestions there. But this is still not well defined in terms of how do we define under assistance when we can define it easily on volume control, but in pressure control it's a little bit more tricky because it has to do with the amount of event for PMOS and measuring the PMOS, or unless the pressure is going below the baseline. Roberto?
Yep, looks good.
Yeah, it's very, very, very tricky. So you would have to, so I would say that there's assistance. Now, I suspect that there's under assistance just based on this. And I would also highlight that this mode, pc-cmva, behaves almost the same as volume controlled cmvs. And so just for you to be aware, okay? All
When you
right,
say it behaves almost the same, what you mean is as the PMUS goes up, the airway pressure goes down, P vent goes down.
exactly, exactly. And the difference is that with pc-cmvs, you would not get the flow. So I presume that by having the ability of flow to increase and maintaining the pressure on the airway, the work of breathing and the assistance is better on volume control for any given level of PMOS compared to volume control. So pc-cmva, if you grade it, it would be would favor more on their assistance versus pc-cmva. Do you agree with that, Roberto?
Intuitively, yes, but I don't know of any research to support it. That'd be a good project to check out. You could look
Mm-hmm.
at intra work or intracycle power or something like that.
Mm-hmm. Very
Mm.
good. And then in terms of cycle, you can see that there's this little big, and there has been disagreement if whether this means early, late cycle or not. Yeah, so the literature and the way that we have been classifying is that it's normal because there's no effect in the flow. There's no evidence of a step up or that it affects the expiratory flow, and that this may be just the way that the ventilator doesn't have chance to adjust the pressure to achieve it. Now, if it was pressurizing appropriately, or if you can shorten the I time and this disappears and there is no evidence of early cycle, you could argue that this was a late cycle. But I would say just by the flow waveform that we have here, I would say that this is normal. Roberto?
Even if it was late, it's probably not clinically important, right?
Correct. I would call it normal. And then expiratory work, we talk about that again. And I just for the sake of love, I put this one, which is the same patient. If you notice it, this is the patient, and a couple of seconds later, this is the image of this patient. And just for the sake of time, for all of us to recognize, again, the patient is triggering, so it's patient triggered, but this is an early cycle, so you can see that the patient now PMOS continues, and if you would graph the PMOS for this patient, it starts here and it ends all the way over here. So all of this is PMOS, and you can see that it's longer than the ventilator I time, and because it's shorter, the ventilator I time, so it's cycling early, so this double trigger is occurring because of that. You can see the same on this one now. You have two, it goes all the way from here to here. And then there's this And actually this makes the point. You can see that there's no flow, so the patient is relaxed. There's no flow because this ventilator doesn't let you exhale unless you pass certain threshold. And you can see that the pressure now it's demonstrating actually what would be the pressure of the relaxed system, so the plateau pressure in the respiratory system. Roberto?
I would say that the message here is that the decision was to support comfort and not safety, and they didn't do it in a way that promoted comfort.
Absolutely. Absolutely. So, and you can see here, but there's a story that I wanted to say here, which is this patient put in here 650, and in the next breath he put in around what 50, 84 actually. You can see it 84 cc. So it put 730 cc's of air. That's because it was on PRVC. When it was on volume control, the patient is forced to have the two breaths. So it got 450 and 450, 950. So as you start thinking about the value proposition of in which mode it may be more dangerous to have a double trigger, we have to recognize that some of these one may put you at risk of overdistension volutrauma. This may put you at other risk in terms of the diaphragm or muscle trauma, if we want to discuss that. But they don't behave the same, even though they cause the same discordance, which is a double trigger pattern. Roberto?
Yep. So the message to me is that you shouldn't have this patient being subjected to mandatory breaths with an arbitrary inspiratory time. Let them cycle off themselves.
So, and just Satoshi came to me the other day and said that everything was good and pretty, but that we should do a little summary when we finish all of this. So we looked at volume control, CMV, and we compared this with actually pressure control, CMV, A. And what we saw here is that there were a couple of differences on the way that they behaved in terms of under assistance versus what seemed to be assistance, just because of the way the comparing pressure control versus a flow that it behaves on the same way. We also had the opportunity to see double trigger, and this double trigger that occurred on both, in volume control, it led to double, 2 times the tidal volume. And in this one, in pc-cms, it led to double trigger, but it actually had less tidal volume. It still was higher than expected, but it was the tidal volume was not as high as it was. Then we talked and made very clear that the key here to manage this patient is to make a decision regarding what's the goal. And when you make the goal, that will help you make the decision. If you go into the goal of comfort, your first item would be then to probably liberate the item in this patient so that the patient would have, even if you just put for that moment of time when you make your mind to pc-cms, the patient will be good. So with that, we finish the Satoshi summary. And here are the CMEs for CCF caregivers and the CRC for RTs. And as usual, please go into our YouTube channel and see all the videos that we have put there. There's a lot new ones. And thank you for being with us. Thank you. Thank you, Roberto.
Thank you, Eduardo.